Welcome to AETCM, the emergency medicine channel. Today let us discuss about hypertensive emergencies, that means management of high BP in emergency room. Hypertensive emergency means very high BP with end organ damage like kidney failure, retinopathy, cardiac diseases, stroke. All these things are end organ damages. Severe asymptomatic hypertension or hypertensive urgency. It is defined as very high BP, 180 by 110 millimeter or more than 110, without acute organ damage. So, if there is no target organ damage but BP is very high, we can call it as hypertensive urgency. Both are slightly different in terms of management. Malignant hypertension means very high BP which suddenly come into picture. That time patient can have associated features, that is malignant hypertension. So the emergencies are hypertensive encephalopathy, patient can have altered behavior, headache, vomiting, seizures, sometimes stroke-like symptoms. Hypertensive nephropathy is hematuria, proteinuria, progressive elevation in creatinine, intracranial hemorrhages, and that can induce altered behavior, seizure, all these things. Aortic dissection, patient can have difference in upper limb and lower limb BP. Later patient can develop hypotension and shock. Preeclampsia and eclampsia, that is that occurs during last terms of pregnancy, and the ultimate treatment of eclampsia is delivery. Pulmonary edema, that is mostly because of left ventricular failure or failing heart with high BP, can produce pulmonary edema. Unstable angina or myocardial infarction, that can be a part of atherosclerotic disorder associated with hypertension. So these are the emergencies. So whenever we get this type of cases, we have to reduce the BP more faster than a normal high BP. So these diseases can aggravate if the BP is very high, so we should be very careful in managing this type of conditions. So many patients who have high BP, they can have associated symptoms, like some patients can have head injury, head trauma, and bleeding, intracranial bleeding. Many patients with high BP can be having neurological findings like coma, seizures, delirium, visual disturbances, hemiplegia, or complete weakness of all the limbs. Fundus may show hemorrhages, exudates, and papilledema. This is mostly because of hypertensive retinopathy. Patients who have diabetes with hypertension can also have diabetic retinopathy. But whatever it is, bleeding in fundus can be dangerous. The patient can lose his vision. Papilledema is one important finding which can tell you that whether the patient has developed brain edema or not. Patient also can have vomiting, bradycardia because of raised intracranial tension. Many patients can have severe chest pain. It may be due to aortic dissection or it can be due to ischemic heart disease. Dyspnea can be there in many patients because of pulmonary edema. Pulmonary edema mostly occurs in left ventricular failure. If the BP is very high and if the patient is already having left ventricular failure, the chance for pulmonary edema is very, very high. Pregnancy, normally it can lead to some amount of increase in BP, but in eclampsia, patient can have very high BP, seizures, some patients can have altered behavior. All these things can be there. Now we have to take the history of drug intake. Patient can have high BP because of the drugs or recreational drugs they use. So we have to take a detailed drug history, whether the patient is taking any medicine which can produce high BP or patient is on any drugs which is used as antihypertensive therapy. Both are important. Now whenever we get a patient with high BP in emergency room, we have to thoroughly investigate this case. So we can take an ECG that shows LVH. Echo also shows LVH, and it can even tell whether there is a reduced ejection fraction or not. Ultrasound abdomen can pick up polycystic kidney disease if it is present. Renal Doppler is used to rule out renal artery stenosis. Fundoscopy is very important. Ophthalmic examination is very important, because patient who is having high BP can be due to temporary problems, like whether patient can take some medicines or recreational drugs which can induce BP. So fundoscopy will tell you that whether the patient is having long-standing hypertensive disease. In long-standing hypertensive disease, you can see changes like silver wiring appearance, copper wire appearance, exudates, hemorrhages, and papilledema. Papilledema always indicates an acute problem, but the other hypertensive retinopathy changes are seen in chronic hypertension, uncontrolled hypertension. We can also look renal failure features like elevated creatinine and urea. Urine routine shows most of the patients who is having hypertensive disease or diabetes, we can get proteinuria. So urine routine is very important. Potassium is very important electrolytes in high BP, because patient who is having Conn syndrome, we can get hypokalemia. In that type of patients, urine potassium levels will be very high. So potassium is electrolyte which can dilate the blood vessels. If it is low, you can get vasoconstriction that induces hypertension. So hypokalemia, hypertension, alkalosis with urine increased loss of potassium always indicates conditions like Conn syndrome. Hemoglobin percentage, many patients who is having high BP because of obstructive sleep apnea syndrome can have high hemoglobin because of secondary polycythemia, so hemoglobin can be done. Lipid profile, many patients who is having hypertension, diabetes can have high cholesterol levels, so that should be done. Thyroid function test, again the hyperthyroidism and hypothyroidism both can have high BP. Troponin I, cardiac enzymes like CKMB, troponin T, troponin I, all can be elevated in patient who is having coronary artery disease when it is associated with high BP. Now this ECG shows LVH. You can see prominent S waves in V1, prominent R waves in V6. When we add up these two areas, we get more than 35 small squares or 35 millimeters. So that's a diagnostic criteria for LVH. So ECG shows LVH with strain pattern. This is a classical finding you get in patients who is having left ventricular hypertrophy because of chronic hypertension. So any patient who is having high BP, always remember, check the fundus if possible and take an ECG. If that ECG is normal, then mostly this hypertension is recent onset. In any patient who is having chronic hypertension which is uncontrolled, we can get left ventricular hypertrophy with strain pattern, and fundus may shows hypertensive retinopathy changes. So this is hypertensive retinopathy changes. You can see copper wiring appearance and silver wiring appearance, AV nipping, you can see the upper part AV nipping, and hemorrhages can be there, cotton wool spots can be there, and patient who is having very high BP, you can see patient is developing papilledema. So this classification of hypertensive retinopathy is called as Keith-Wagner's classification. Now reduction of BP is very important in hypertensive emergencies, but remember, drastic reduction in BP can be sometimes dangerous for internal organs, because when the patient is having long-standing high BP, all our internal organs are set for this high BP. Suddenly, if we remove that high BP, reduce that high BP, internal organs will suffer because of relative hypotension and relative reduced blood supply to the organs. So reduction of BP is very important. Drastic reduction of BP should be avoided. So whenever we get a high BP patient, there is a tendency for doctors to give sublingual nifedipine preparation. Previously it was a treatment of choice, but remember, nowadays it is contraindicated. We should never give sublingual nifedipine because it produces drastic reduction in the BP that can produce relative ischemia to organs which was well perfused with high BP previously. So remember not to give sublingual nifedipine, and remember not to reduce BP drastically. So we should never reduce the BP very fast or very low. So if we try to reduce the BP very fast towards the normal range in a hypertensive emergency, that can produce adverse effects in that patient. So we can see around 10 to 20% in first hour you can reduce the mean arterial pressure. That is very, very important. And by next 23 hours you can reduce to 5 to 15%. So 15 to 35% in mean arterial pressure reduction is only required for the patient. Okay, unless until there is a significant problem like pulmonary edema or severe intracranial hemorrhage, BP should be reduced slowly over next 24 hours. Around 25 to 35% you can reduce, and this mostly can reduce by target BP of less than 180 to less than 120. That is more than enough. And next 24 hours you can reduce to less than 160 by less than 110 in next 24. So first hour it should be reduced to less than 180 by 120. Next 24 hours the target should be less than 160 to less than 110. So if we reduce the BP drastically, it can produce internal organs damage. This is called as J-curve response. You can see that when the BP is very high, systemic BP is very high, it can produce a lot of cardiac and renal mortality. The patient can develop chronic heart disease, chronic kidney disease if the BP is not getting controlled. At an optimum level of BP, all these problems can be well controlled. So renal failure or cardiac failure can be controlled with an optimal reduction in the BP. But if we reduce the BP further, then it can produce adverse effects on the organ because of the reduced perfusion. Like patient can have more cardiac mortality and more renal mortality. So should be very careful when we are reducing the BP. This is called as J-curve phenomenon. So you can see here J-curve response. When the elevated BP is lowered, the cardiovascular events decreases initially, but lowering BP below a critical point, it is not beneficial, and possibly it can produce deleterious effects in the kidney and heart. So mainly patient can have cardiac problems and patient can have renal diseases. So when we are reducing the BP very drastically, we can see that cardiac enzyme will be elevated without any cardiac lesion, and we can also see that creatinine is elevating without any kidney disease. These all are because of reduced perfusion of the organs, because all our organs in our body are set for this high BP for many days or many months. Suddenly if we are reducing the BP, these organs can suffer. The maximum suffering organs are heart and kidney. Now in stroke with high BP, we have to reduce the BP a little more carefully. So antihypertensives like labetalol can be used if the BP is more than 220 by 120, and BP should be reduced slowly by 10 to 15%. If thrombolytics are given, then the BP should be maintained less than 180 by 105 millimeter of mercury during the treatment and for next 24 hours. So in stroke it is slightly different, because we cannot in ischemic stroke, if you reduce the BP drastically, like previously we discussed drastically, there is a problem which like the ischemic penumbra. Ischemic penumbra in stroke means there is a core area in an ischemic area. Surrounding area is called as ischemic penumbra. If we remove the BP drastically, if we reduce the BP drastically, the penumbra also may suffer, and that part also may die. So reduction of BP drastically in an ischemic stroke can kill even the ischemic penumbra. Otherwise, if we reduce the BP in a controlled manner, you can save that ischemic penumbra. So we should be very careful to reduce the BP in ischemic stroke. Whereas in hemorrhagic stroke, we should always target a mean arterial BP of less than 130 millimeter of mercury. And if the bleeding is not stopped, target BP, systolic BP can be 110 to 120 millimeter of mercury in hemorrhagic stroke. There is a condition called as posterior reversible encephalopathy syndrome, PRES syndrome. This is a clinical and radiological syndrome characterized by severe headache. Patient can have seizures, altered mental status, and visual loss. That is very important because posterior it's a posterior circulation problem, so patient can have visual loss. This is due to vasogenic edema affecting the posterior occipital and parietal lobes in the brain. So it is due to vasogenic edema when the BP is very high. So this is posterior reversible encephalopathy syndrome. So it's reversible. It's like a stroke, but it is reversible. This condition will have very high systemic BP. BP control should be very fast in hypertensive encephalopathy. Like patient can have severe headache, nausea, vomiting, seizures, all these things. BP should be reduced 10 to 20% during the first hour of the treatment. And it should not be more than 25% by next 24 hours. In autonomic dysfunction also you can get very high BP, especially in stroke, Guillain-Barré syndrome. All these conditions we can get autonomic dysfunction. There also you can get sometimes very high BP and tachycardia. Sometimes patient can have hypertension and bradycardia. Beta blockers like labetalol has got good action on this autonomic dysfunction that can be tried. Pheochromocytoma is an endocrine disorder where you can see episodic high BP with tachycardia. Here also we have to control the BP, but remember beta blocker alone, if we are giving in patients who is having pheochromocytoma, BP can increase because of unopposed alpha activity. So alpha blockers has to be started first, then only we can start beta blocker. So we should be very careful in controlling the BP in pheochromocytoma. But it will be difficult in emergency room. Whenever we get a high BP with tachycardia, we naturally give beta blockers. But if the BP is not getting controlled with a good dose of beta blocker, or rather the BP is increasing with the beta blockers, we have to think about pheochromocytoma in a young patient who is having episodic high BP with tachycardia, palpitation, sweating. We have to add an alpha blocker with the beta blocker if we have doubt. Otherwise straight away start alpha blocker in a young patient who is having palpitation, tachycardia, sweating and suspicion of pheochromocytoma. We start alpha blocker first, then beta blocker. Now there are some conditions where the BP should be reduced faster than what we discussed in the previous slides. Generally in 24 hours normally we reduce the BP by 25% of the admitting BP. But in conditions like severe stroke, acute stroke in a massive stroke, aortic dissection, intracerebral hemorrhage, or patient is having pulmonary edema, all these conditions sometimes we have to reduce the BP drastically, especially who is having pulmonary edema, aortic dissection, intracranial hemorrhage. These are the three conditions. And massive ischemic stroke also sometimes we will have to reduce the BP drastically, because there in that condition we are not thinking about ischemic penumbra, because there is a large area is destroyed by the stroke, and if we don't reduce the systemic BP, sometimes the raised ICP can kill the patient. Acute aortic dissection, we have to be very careful, because many patients during the reduction of BP with powerful drugs can go to hypotension and shock. But however, the systolic BP should be rapidly reduced to a target of 100 to 120 millimeter of mercury in 20 minutes. We can use beta blockers because beta blockers also reduces the heart rate. So in conditions like aortic dissection, heart rate control is very important. So we can use beta blockers to control the BP. We have to reduce the BP very fast and drastically so that the dissection speed can be reduced. Head trauma also we have to reduce the BP fast. So hypertension is usually treated in these settings only if the cerebral perfusion pressure is more than 120 millimeter of mercury and the ICP is more than 20 millimeter of mercury. Then we have to control the BP fast. Now, there are some drugs we'll discuss here which can be used in emergency room to control the BP. In that, one of the commonly used drug is sodium nitroprusside. So this drug can be given in very high BP, but we have to cover the drug completely because light exposure can induce toxicity for this drug. So it's a vasodilator. 0.3 microgram per kg per minute can be started, and usual dose is 2 to 5 microgram per kg per minute. So the infusion bottle and the line should be wrapped with aluminum foil, otherwise it can be it can become degraded or become toxic during the infusion by light. NTG is another drug. It has got similar effect of sodium nitroprusside. It's a vasodilator. Start with 5 microgram per kg per minute, increase by 5 microgram increments. You can give very high doses in hypertensive patients. Unlike patient who is having coronaries, we may not increase to very high doses. Here up to 200 micrograms you can give. There is advantage of NTG. But remember, NTG and SNP should not be continued over more than 24 hours. After that, they produce tachyphylaxis. The receptors for these drugs will be deactivated, so it will not be the drug will not be effective. So sodium nitroprusside and nitroglycerin. Sodium nitroprusside should not be given in patient who is having renal failure. Another important drug is labetalol. So almost all conditions we can use labetalol. It's a very safe drug. Almost all type of hypertensive emergencies you can give these drugs, except patient is having severe bradycardia or patient is having pheochromocytoma. So you have to remember, severe bradycardia we cannot use this. A patient who is having tachycardia because of pheochromocytoma also we cannot use this drug. Otherwise we can use this drug. So initially 20 milligram IV push over 2 minutes. It can be repeated 20 to 80 milligram every 10 minutes, or you can use it as an infusion 2 milligram per minute. That can be given as an infusion. So we can see the chart here. There are large number of drugs available. So we have labetalol, we have furosemide, that is Lasix, you have NTG infusion, you have sodium nitroprusside infusion. If you see this chart, almost all conditions you can use labetalol. It's a very safe drug, very useful drug. It has got both alpha and beta activity, blocking activity. It can be used in almost all conditions, but remember, in pheochromocytoma we have to give a proper alpha blockade before giving this beta blocking drug. Then another important drug is Lasix or furosemide. So most of the conditions except like Conn syndrome, where the potassium is very low, we can use Lasix, like a patient who is having pulmonary edema, patient is having myocardial infarction. Any condition we can use Lasix. But remember, patient who is having hyperkalemia, we should not use Lasix in emergencies. Lasix can be given as push, IV push. In that, BP can be reduced immediately, or it can be given as an infusion. When we are giving infusion, it will remove the fluid and salt from our body. So So almost all conditions we can give Lasix except in hypokalemic patient. Other drugs like NTG, SNP, they can be used in most of the conditions, but SNP should not be used in patient who is having renal failure. So we have discussed about one of the important emergency, that is hypertensive emergency. When we treat hypertensive emergency, we have to think about the J-curve response. J-curve response or J-curve phenomenon is when the BP is high, it can produce adverse effects. When the BP is optimal, it can be good for the patient. If the patient develops hypotension because of antihypertensive, it can produce more damage to kidneys and heart. So that is J-curve response. So to avoid that in hypertensive emergencies, the maximum allowed range of reduction in 24 hours is 25 to 35% only. We should not try to reduce BP to a normal level in 24 hours. That can produce sometimes damage to the kidneys and heart. And always try to avoid sublingual nifedipine. That is not a good choice at all in any hypertensive emergency. In patient who is having pulmonary edema, Lasix with NTG will be a very good choice. Patient who is having all other conditions, beta blockers are a very good choice, but beta blockers cannot be used in severe bradycardia or pheochromocytoma. Thank you.